Sure thing. Good morning, everybody. My name is Sara Dugan. I'm a psychiatric pharmacist and faculty at Neomed. I get to present this morning. And our topic for today's didactic is drug interactions. So this is going to be part of a series that'll be spread out over the course of the next few months. Looking at drug interactions in treatment for substance use disorder. So we're starting with drug interactions and medications for opioid use disorder. So 3 things I hope to accomplish this morning. So one is to define pharmacodynamic and pharmacokinetic drug interaction. So recognizing that we're looking at both. To list the drug interactions associated with medications that are used for the treatment of opioid use disorder, and then to describe some strategies for managing those drug interactions. So I wanted to start with general definitions. So drug interaction in general is a reaction between 2 or more drugs that results in the drug being more or less effective. And I think this is an important consideration because a drug interaction sometimes can be a good thing. We look at drug interactions related to treatment of patients who have HIV, and they're built into the drugs that we use. Many of the combinations include things like ritonavir that can be boosters. So they interfere with the metabolism of some of the other antiretrovirals so that we get higher concentrations to improve the efficacy. So drug interactions isn't always a bad thing, but unfortunately, many of the times we're being reactionary to the interaction, and we're having to kind of deal with whatever the fallout was as a result of it. So if the drug is more effective, then potentially we're seeing greater impact of that medication. It may also mean more adverse effects. On the flip side, if it's less effective, it may mean that we've lost the efficacy that we had, and we're not achieving those treatment goals that we might have been achieving previously. Now, those interactions, so it can be a drug, it can be a supplement, it can be a food interaction. We're going to focus just on the drug interactions for today. These reactions can fall into 2 different categories. So the first category is pharmacodynamic interactions. So pharmacodynamics is what the drug does to the body. So these are reactions between the drugs based on how they work. And I think a good example of that are 2 sedating medications. So if we have more than one medication that causes sedation, we may see excessive sedation. So patients not just tired, they may sleep for a much longer period of time. The other type of interaction are the pharmacokinetic interactions. So pharmacokinetics being what the body does to the drug, how the drug gets in, where the drug goes, how it's metabolized, and then ultimately how the body gets rid of it. So these reactions are going to influence any of those steps. Most of the ones we're going to focus on today really are related to metabolism. So the enzymes that actually break down the medication so the body can get rid of it. We'll talk quite a bit about inducers and inhibitors, and I think I have a slide here, either next or in 2 slides that's going to look at this a little bit more. But if we're influencing the metabolism of the drug, we directly can increase or decrease those concentrations. So that tends to be one of our main focus areas when we think about drug interactions. So those enzyme considerations, it was the next slide. So we have 2 different types of interactions that can happen. So induction and inhibition. So induction means that the body is now making more enzyme. So the enzyme is a protein. It takes a little bit of time for the body to get the signal that it needs to make more enzyme, to create all of the bits and pieces that it needs to put that enzyme together and then get that enzyme up and rolling. So it's not something that happens right away. It's an effect that we tend to see over time, usually over about 1 to 3 weeks, with full impact being more prevalent after about a month of being on an inducer. By having more enzyme, we get more metabolism, so a greater ability to process the drugs that are in the system. By having more metabolism, that means our drug concentrations are lower. So that enzyme is chewing through more of the drugs. So we see lower concentrations. We also can see diminished efficacy. Doesn't mean we can't use the drug, but we may have to do some dose adjustments, increasing the dose to be able to maintain the efficacy we had gotten previously. I just went over this with my pharmacy students as we were doing the epilepsy lecture because several of our seizure medicines are inducers. And I use the tortoise and the hare as the example. So induction is a big deal, but it tends to be the tortoise. So it's not something we're going to see right away. The opposite of that is going to be the inhibition. This is the hare. This happens very quickly. So these medications that are inhibitors can bind to the enzyme. They bind to the enzyme and make it less efficient. It's not as able to process the medication. So if it's less efficient, we have less metabolism. Less metabolism means we end up with higher concentrations. So those enzymes are not able to chew through the drug, and those concentrations stay higher for a longer period of time. In some cases, like the HIV example I gave previously, that's what we're looking for. We want those higher concentrations to be able to fight off the virus. But in many other instances, that may mean those higher concentrations result in more adverse effects, greater toxicity, and that can be problematic. Again, doesn't mean we can't use these medicines, but we may have to dose adjust. We may have to lower the dose of those medications to prevent any adverse effects. So those really are going to be the types of interactions that we're focused on. Why did I pick this? Why did I pick this as a series? None of it really is going to be groundbreaking information, but it's a good reminder. Interactions can drive adverse drug outcomes, which can increase financial costs, may result in hospitalizations. We may see increased morbidity and mortality for some of the patients, may ultimately result in treatment failure and ultimate complications for the patients. So kind of keeping this in mind as a refresher, hopefully can have us monitoring and screening so we can prevent some of the more adverse reactions or severe reactions. So for today, I just wanted to focus on the medications for opioid use disorder. I split them out into 4, so I recognize naloxone is in combination with buprenorphine, but there are different considerations for each of them, so that was why I pulled those 2 apart. Naloxone and naltrexone work very similarly, so we've got those back to back, but we're going to start with buprenorphine. Not because it's the favorite, but because alphabetically it comes first. So buprenorphine, it is a partial opioid receptor agonist. So we're going to look at, from a pharmacodynamic interaction, there are going to be some effects related to that, especially related to some of the sedation possibilities. So other medications that can increase sedation. So pharmacodynamically, we do see some interactions. And then pharmacokinetically, it does use some of the enzymes that can be impacted by inducers and inhibitors. So it is metabolized by the cytochrome P453A4 enzyme. So this particular enzyme is very popular. It metabolizes a large number of medications, buprenorphine being one, and it is very susceptible to drug interactions. So we have several classes of medications that interact with buprenorphine, and we're going to look at them individually on the next slide. So of those interactions, I broke them into subcategories. So many of those classes of medications can increase the adverse effects. So buprenorphine is an opioid agonist. It has similar actions to other opioids. One of those actions being sedation, constipation, which could potentially be made worse by other medications, things like anticholinergics. Before we started today's session, there was discussion about all of the illnesses that are floating around right now. So as folks, or even the fact that it's kind of allergy season for a whole bunch of people. So this may be a good time of year where folks need an anticholinergic. So they may be using something like Benadryl a little bit extra because they are having some additional symptoms. Well, that may result in increased sedation. It also could exacerbate constipation if they're on the buprenorphine. If they're going to use it for a short period of time, that's probably okay, but something that we'd want to be mindful of if they need it for an extended period of time. Other classes of medications that interact, so the benzodiazepines overall tend to be a CNS depressant, so they have the potential to increase sedation in patients who are on buprenorphine. Chances are that may be something that gets added and the prescribers are aware that that's coming on board, as opposed to the anticholinergics, which could be gotten over the counter. But really ensuring that patients are aware that that may happen with any of the other CNS depressants they may be using. Many of them are prescription medications, so antipsychotic medications, some of our seizure medications, cannabis. Any of the cannabis products also can cause some CNS depression. So ensuring that they're aware of that and that they're not operating machinery right away. If it's really going to knock them out, they won't be able to respond very quickly to any situation if they're operating a car. So, or if they have to do something that requires a lot of attention. If they're using this combination during the day, they need to be up and alert for their job. They may find themselves falling asleep at work. So it is something they need to be mindful of. The last increased adverse effect is with serotonergic medications. So the opioids, many of the opioids, have been found to also prevent the reuptake of serotonin. So they increase the serotonin tone a little bit more. They're not completely antidepressants or anxiety medicines, but sometimes that can be just enough to add additional adverse effects. In this case, it may be adverse effects of those serotonin medications, things like our SSRIs or SNRIs, so fluoxetine, sertraline, venlafaxine, any of those. So gastrointestinal effects, it may impact their sleep cycle. So if it makes them tired, it would make them more tired. If they tend to get insomnia from the serotonergic drugs, it would cause that. So we could see some adverse effects as a result of this combination. Can they be used together? Yes, it's possible they may become tolerant to it, but we may also have to make some dose adjustments, either of the buprenorphine or of the antidepressant. Probably more likely the antidepressant if that's the one causing the adverse effects. So now we're going to shift into our kinetic interaction. So we have both inducers and inhibitors. As promised, there are a number of seizure medicines that are inducers. So carbamazepine, phenytoin, and phenobarbital are the three big ones. Rifampin also has pretty significant induction. And then St. John's wort that patients could get over the counter. So these would increase the metabolism of buprenorphine, which means that we may end up with lower concentrations. So in the event that these are added to a regimen, we may need to reevaluate because the patient may no longer have efficacy. They may notice some breakthrough symptoms, and we may have to do some adjustments to the buprenorphine dose. On the other hand, the inhibitors, so there are several inhibitors of the 3A4 enzyme. Some antibiotics, so clarithromycin or erythromycin, some of our calcium channel blockers, so cardiovascular medications like diltiazem and verapamil, some of our antidepressants. So that combination in general seems to be tricky. And then ritonavir, again, the HIV medication that we had talked about boosts some of the other concentrations. So if these are used with buprenorphine, again, we can see some adverse effects. If they're short term, like the antibiotics, maybe we'll just, for a short period of time, have to reduce the dose. If it's something that's going to be more of a longer term treatment, like the calcium channel blockers, that's probably not going to be a short-term treatment, then we may need to look at overall reducing the dose or seeing if there's a different medication class that we could use. So in looking at buprenorphine, we've got increased side effects and effects, or the decrease in the concentration where we're seeing less effect from the buprenorphine. Monitoring is going to be very important. And I think evaluating. So if we see a combination that's potentially problematic, does that need to continue? If there's other agents we could use, so if a calcium channel blocker is being used for high blood pressure, well, we've got several other options we could potentially use. Can we shift to something different that wouldn't interact with the buprenorphine? That would be ideal. If the answer is no, we really do need that, then we need to keep watching. So what happens? Do we have to make preemptive changes to dose? No. because we need to see what's going to happen in the patient. In the event that they do get some adverse effects, we could reduce the dose of the buprenorphine. And then in some cases, if there's more side effects, we may have to look at other interventions. So if a patient is on an anticholinergic, they really need something for their allergies or because they're feeling ill, but they're incredibly constipated, then potentially we do add another medication on board, something like a laxative to assist with the constipation, but we'll want to continue to reevaluate because ideally we're not trying to continue to add things to their medication profile. On the other side, with our inducers, if we've lost some efficacy, then we may have to look at increasing that dose of the buprenorphine. So quite a few considerations with the buprenorphine. We're going to see some repeats here with methadone, and then we're going to see a couple new classes that pop up. So methadone also being an opioid agonist, it also works on the glutamate receptor. So it's an N-methyl D-aspartate antagonist, so the NMDA antagonist. And it also is metabolized by a number of cytochrome P450 enzymes. 3A4 pops up again, but also 2B6, 2C9, and 2C19. One of the unique adverse effects of methadone is that it can prolong the QT interval. So it has the potential to change the cardiac rhythm, which may mean that it could lead to an arrhythmia, which can be problematic for patients who do have other cardiovascular considerations. So we see that pop up as a drug class that could be potentially problematic with methadone, along with most of the other medications that we saw. Muscle relaxants were called out specifically. Methadone can be used for long-term treatment of pain, and there has been an increased risk of CNS depression when it's used in combination with the muscle relaxants. So yes, muscle relaxants can pop up in the CNS depressants, but in the prescribing information, it was listed separately just because the combination has been used and has been reported to be problematic in some patients. So that's why that showed up differently. So in thinking about this, the antiarrhythmics give us a whole new group of medications that could potentially be problematic. So some of the medications that are used to treat arrhythmias, when used with other medications that can cause arrhythmias, we may see some changes in the EKG. So amiodarone, our antidepressants, specifically our tricyclic antidepressants, can potentially cause arrhythmias. SSRIs can do that as well, but it tends to be a little bit more common with the tricyclics, especially higher doses. Most of our antipsychotic medications can also prolong the QT interval. Our calcium channel blockers, so they've popped up a couple times. And then agents that can change the electrolyte concentrations. So if we do see shifts in electrolytes, so specifically potassium, it may change the risk of a patient developing an arrhythmia. So some of our water pills, like Lasix or furosemide, can potentially interact with methadone. So in the event that patients are on these combinations, watching for new signs and symptoms, and it may be worth getting an EKG, especially baseline and then follow-up. So we have something to compare it to see if there was a change. If there is an arrhythmia, patients having symptoms, we can consider reducing the dose of methadone. So doses above 100 milligrams are more likely to cause arrhythmias. Can they be controlled on a lower dose? If the answer is no, we may need to look at discontinuing one of the medications that's causing the interaction, whether we can move from methadone to another treatment for opioid use disorder, or if they're on an antidepressant like a tricyclic, could we move to a different class that would be less likely to cause an arrhythmia? So maybe using one of the SSRIs. Could we potentially use something like mirtazapine, bupropion, something that's not necessarily going to cause those arrhythmias? The adverse effects, all those classes on the other side, very similar to what we saw with buprenorphine. Again, watching for those adverse effects. Can we reduce the dose? Can we reduce the dose of the methadone? Can we reduce the dose of any of those offending agents? And if not, or we did reduce the dose and we're still having trouble with adverse effects, then maybe we need to look at making some modifications. And to be complete, the inhibitors and the inducers. This is not a complete list of inducers and inhibitors, but these were the medications specifically called out in the methadone prescribing information. Again, inhibitors are going to increase the concentrations. We're probably going to need to lower the dose. Inducers are going to lower the concentration. We may need to raise the dose for those. Not that they can't be used safely, but we do need to be alert and aware, and then intentional in terms of monitoring to make sure we make those adjustments. Last two, so naloxone is the first of our antagonists. So now we're blocking the opioid receptors. And from a pharmacokinetic perspective, we don't have the same considerations. So it is metabolized through the liver, but it doesn't use the cytochrome P450 system, and we don't see as many interactions related to that. The biggest interactions we see with the naloxone are with the opioid agonists. So it's going to block the activity of the opioid receptor. So in the event that a patient does need an opioid agonist, it's going to be less effective. It may be worth having either a medical alert card or some type of wearable, whether it's a bracelet or a necklace, something that alerts healthcare personnel. So if a patient's in an accident, is not able to provide their medical history and they require surgery where they're going to need some type of pain control, that alerts the healthcare professionals that this is on board and may be problematic for them. So that really is the biggest issue with naloxone. Naltrexone looks similar. So also the opioid receptor antagonist, hepatically metabolized, but again, not using those cytochrome P450 enzymes. Opioid agonists still problematic, especially if patients are on the long-acting injection. That would be something to make sure that they're mindful of. But the other interaction that pops up with naltrexone is with hepatotoxic medications. So there is a risk for liver damage with naltrexone in the event that they're taking other medications that are potentially hepatotoxic. It increases the risk that we may see some elevations in the liver function tests. We need to watch for those side effects. The monitoring, so we can monitor liver function tests, although for naltrexone, it is possible, and it happened pretty frequently, that even with routine monitoring, the hepatotoxicity pops up anyways. So really watching for signs or symptoms that come up if a patient starts developing jaundice, if they're having gastrointestinal issues, at that point, we may want to investigate that a little bit more. But I point that one out because another over-the-counter medication could potentially play a role. So in the event that a patient's not feeling well, again, they get one of these viruses or illnesses that's going around right now, they feel like they aren't feeling their best. They're taking Tylenol on a regular basis. If they're using combination products, sometimes the amount of Tylenol that you take can become toxic. So that in combination with the naltrexone may be somewhat problematic. So minimizing the impact, really making sure we have a comprehensive medication list. What are you taking prescription-wise, over-the-counter-wise, and even recreationally? So if they're using alcohol, if they're using cannabis, those both being CNS suppressants, could be problematic. Long-term alcohol use with the naltrexone could also increase the risk for the hepatotoxicity. If they're making any changes, making sure they're letting their healthcare team know. And then watching for any changes in the patient. This was effective and now it's no longer effective. We're seeing new adverse effects. What might have changed? Looking, can we get rid of the interacting medications? Or if we have to continue them, what dose adjustments may we need to make? And trying to avoid adding extra medication. So I use the constipation example. That's kind of a good one because hopefully short term they're using their medication for their allergies. So maybe short term they need something for constipation, but we'd ultimately not want to participate in the prescribing cascade where we're treating adverse effects with more medications, increasing the likelihood patients going to have additional adverse effects. So just in summary, drug interactions, so a result of either the way that the medication works or the way that the body processes the drug. And there are several interactions specifically related to our medications for opioid use disorder. But with routine screening and kind of keeping an eye and intentionally monitoring that and asking if there are new medications on board, we should be able to minimize the adverse outcomes as a result of these. So with that, I will stop my share and turn things back over.
Thank you, Sarah. Does anybody have